chat, where we will discuss the latest in research and treatment and what every oncology nurse should know. I would like to introduce what City of Hope is all about. City of Hope is an independent biomedical research institution and comprehensive cancer center committed to researching, treating, and preventing cancer, with an equal commitment to curing and preventing diabetes and other life-threatening diseases. Our mission is to transform the future of health by turning science into practical benefit and hope into reality.
Before we start our discussion, if you're watching us on Google+, you can submit your questions through the Q&A app. If you're viewing the broadcast from YouTube, annotations are available on the video. The annotations will point you to the Hangout on Air page with a Q&A app. If you're joining our discussion on Twitter, make sure to add the hashtag #NursesForHope to your tweets and questions.
And I'd like to introduce you to our panelists. I'd like to introduce Kate Kravitz from Nursing Research and Nursing, Pamela Harina from Clinical Research Unit, and Kathleen Kelly from the Department of Supportive Care Medicine. So I wanted to go around the room, and if all of you can talk about what your title is, how long have you been here at City of Hope, and what you do in your departments.
Well, I'm the clinical nurse manager for the clinical research unit. So my unit does all the treatments for patients that are on clinical trials. So any treatments that they have, any of the requirements around the protocol for their treatment. We do healthy volunteers that volunteer in our trials. So a lot of patients come through us and get their treatment per the protocol and all the requirements. And we work closely with the clinical research nurses, the clinical research coordinators, and definitely we're connected to the research side.
How long have you been here?
Oh, and I've been here for a little over 2 years.
Great, thank you.
So I'm Kathy Kelly. My position is called the Cancer Information and Resource Nurse at City of Hope. I've been at City of Hope actually since 2006. I did work with my colleagues in nursing research. And now I've been as the Cancer Information Nurse since 2012. It's a different kind of position, as I'm not a bedside nurse. I handle many calls and emails to City of Hope when people ask about services, programs of treatment, and clinical trials at City of Hope. So I might get calls from as far away as Chile, as I did this week, or I get a call from someone in downtown, who lives in Los Angeles, who's looking for a clinical trial for ovarian cancer. I tried it. Sometimes people are newly diagnosed. Sometimes people have been through many treatments. I try to help them understand how clinical trials are structured and what resources are available to help them come to City of Hope or to go to another organization that might be helpful to them.
Okay.
Thank you. I work in nursing research half-time, and for the nursing department the other half of my time. In nursing research, I work with the head of our department on her American Cancer Society funded caregivers study. So we work with caregivers, the intervention nurse there, and we provide a psychoeducational intervention to the caregivers as they go through providing support to their loved ones. And we're about halfway through that particular study. In addition, in my role in nursing research, I sit on our Institutional Scientific Review Board, which is part of our IRB, or Human Subjects Protection Committee, and that's federally required, and required as part of our cancer center status. So that's a very interesting, and if you like science, it's the scientific orientation for looking at how we construct our studies here. The other half of my time is I founded the hypnosis service here at City of Hope, and so nursing has seen that as a really important way for a nurse to contribute in an independent nursing practice within the confines of the institution. So we provide hypnosis to patients for symptom and symptom management. And when I say we, it's kind of the royal we, it's really just me right now. In addition to that, we provide support for pre-procedural anxiety, smoking cessation in patients who are getting ready to go into surgery or for lifestyle change. And we provided at all junctures in the cancer treatment trajectory and in the disease trajectory. So we might see people at the very beginning of their disease process, or we might see people at end of life. So, and I've been here 18 years in January.
Thank you, Kate.
Mm-hmm.
So I'm going to open the discussion. So if you could let people know, what is the typical day as a clinical research nurse here at City of Hope?
So for our clinical research nurses, they're usually part of a disease team. So it could be a solid tumor, GI or GU, or a heme leukemia. And they work with the doctor on the studies. Usually they'll be called with a patient that may be eligible. They work on consenting patients and giving them the full understanding of what they're consenting to, along with the physician. And then they do the screening for eligibility. So all the studies have specifics that you have to meet and be eligible for. And then we have to show proof that they meet that. It could be a certain number of markers in your blood. It could be the size of the tumor, multiple different things, age, activity level. And then they work with getting everything authorized. Of course, also their clinical research coordinators who help them get patients enrolled. There's a lot of work that goes into getting someone onto a clinical trial. So once they're on and enrolled, then they work on scheduling with the doctor, with the clinical research unit. They also provide in-services for my nurses who are doing the treatment. So we kind of know why we're doing this study, what are the requirements that we need, like if there's special testing, EKGs, labs, vital signs, monitoring, anything. Sometimes it could be swabs that we have to do. And then they work very closely with the physician to make sure that they're assessing the patient and that they're allowed to go to the next treatment. There's very specific requirements that a patient has to meet. They can't be, their toxicity can't be at a certain level. It has to be below a level. Their labs have to be at a certain level. And working there to keep patients on their treatment. Of course, they're also the contact for that patient. If they have any questions, if they need to change their schedule, they really have to work with the research nurse so that they're not outside of the window when they have to be treated, because there's a lot of parameters that they have to do. And they're also preparing the worksheets that my unit uses to treat patients. So they're doing a lot of different things, a lot of patient, no real hands-on, but definitely holding the hand of the patient to get them through the system, coordinating their care, and a lot of the data that we need to make sure they're getting treated, putting in orders, and again, working with the doctors to get everything done before they come in and get treatment. So, anyone else would like to?
Well, my role is different because I'm not in the clinical center. So I meet patients. I mean, sometimes I'll meet them in person. They may come to our Biller Family Resource Center, which is there, and they'll come in and they'll ask if City of Hope has any clinical trials for them. And so I have the time and the ability to sit down and listen to where they are clinically. And I ask many of the same questions actually that our other nurses go through. We look at there are resources, and City of Hope has all of its clinical trials that are open online. If you go to our main website, you can click on it, and if you can search by your diagnosis, if you would choose to do that. A lot of people may find that a little overwhelming, so they ask for help, and I'm available to do that. So if someone may come in and they say they have ovarian cancer, so I'll ask what treatments they've had in the past. So because I know we have right now, I know the portfolio we have for ovarian cancer, and I can sort of pre-screen them for what they might be available for. And then I send them that information. So if they're not a City of Hope patient, they can review it with their current medical doctors and then maybe be referred back here and become patients here. And so I help support that by providing the information and resources that they can come here. And I think, we have almost 200 now clinical trials. City of Hope's quite phenomenal in the number of clinical trials that we have ongoing for cancer and diabetes. So.
And for my day, again, we're creating the theme of variability. So for my day being on the types of studies I'm on, it's contact intensive with the patients and the caregivers. So just from looking at today's activity level, I saw 2 of our study patients and spent time providing the intervention to them, which in both cases took over an hour of time just to answer their questions, hang out with them. One case we did it over the phone, the other case we were there with them while they were in clinic. And so it's intensive in terms of where they are in their experience. And sometimes that can be a very hopeful place, and sometimes it can be a place that's really challenging, and they're having to process a lot of information that they probably would have preferred not to have.
Right.
So we spend a lot of the time with them. In addition to the clinical piece, you can have a management opportunity just the way Pamela does with these studies, and that I'm the project director for this study. So my job is to keep it all flowing. So in addition to the patient contact, you have to monitor, where is our data kept? Are we protecting HIPAA? Have the consents been handled correctly? So there's a level of protection. You really are, we talk in nursing about being patient advocates, and there's a lot of ways that is operationalized. On the research side, where you're actually managing a study, you have lots of things to pay attention to protect the patient's private information and their experience. And so that's part of my job. Where is all of that stuff? How has it been handled? Have we communicated effectively when things come up? On the other side, when I'm working with the hypnosis patients, then that too is patient intensive. So I see both the inpatients and the outpatients. Today was an outpatient day. And so I saw 3 or 4 people. And because our system is so accommodating of the patient, I had people calling me who wasn't supposed to see them before 10 o'clock this morning, but they're calling me at 8 o'clock and said, there was no traffic. I got here really fast from the Antelope Valley or wherever. Can you see me? Well, of course, the answer is yes. And so I saw a lot of people today who got here and didn't think that they would get to be seen because of the way the traffic flows and the way the distances and the way the multiple appointments fall, and they all got seen. So it can be really, you have to be a flexible person. And I think you guys would know that too, right?
Now, with clinical research, if anyone wants to go into it, what are the qualifications that all of you recommend? What are the soft skills and the hard skills that you would probably like to mention to our audience today?
Well, I think if you wanted to be a clinical research nurse and work with our physicians in our research department on clinical trials, right now we're pretty open. So if you have a desire, believe in a person's hope, that's a good start. It's nice to have oncology experience or research experience. It's a lot to learn. There's lots of guidelines. There's lots of protections that we need to make sure that we're doing. So it's a lot of things that you're not doing if you're a hands-on nurse. So it's kind of a different way of thinking. Sometimes when you're on the floor, you can go home physically tired. And I always say it's different in the clinical research trial nurse side or the outpatient side, where your brain is just so full sometimes at the end of the day because you have so many things in your brain. Oh, I got to make sure I do this. I got to make sure I document this way. The patient has issues that you want to make sure that you're complying with. So I think a lot of people have gotten into research nursing or clinical research nursing when they work with physicians. Definitely if you work in oncology, there's openings, and I know when I was just doing oncology, I'd been approached by physicians that wanted me, if I was interested in doing their research. So lots of different ways, but I think the biggest thing is that you have a desire for hope, and you believe in someone having hope and allowing them to have that hope and fight as long as they feel they need to.
Well, the qualifications of a clinical research nurse, I think they need two loves. One is perhaps the love of the science and the love of learning and the love of maybe more than two. And then a real love or a real calling to meet patients wherever they are. And that means you use your nursing education and your experience when you listen to the issues that the patients have. And certainly patients that come into clinical trials they've had perhaps a lot of experience being treated, and they come with questions like, what's next? What will this treatment do for me or might do to me? I mean, part of it is helping them. I know that our nurses, helping them understand what side effects might be and how we will help them manage them. If it's the research nurse, so really they need to become educated about the basics, structure of a research program, but then it's another step beyond that, learning the science, but bringing that human factor in so that you can really help communicate with them. And I think that our nurses really do often have that. That's what it's meaningful to both the patients and to them every day.
Yeah, I'll second what both Pamela and Kathy said about the desire, just the interest for one, but number two, this human factor I think is really important, because you're still nurses first. It's what I hear in my office. We're nurses first. And that sometimes is challenging because the structure of research protocols sometimes forces you to examine where are my boundaries in terms of my nursing practice. You have to keep focused on the patient and their needs, because after all, we're nurses first. Yes, we have responsibilities to the studies, but if you have somebody who has that kind of commitment, then they'll translate all of those skills that they have to embrace into a positive experience for the patient.
Thank you. Are there any schools that you recommend where they can get some of this experience, or, should they start out as a research associate, or what things?
I think they have to start out clinically, personally. Okay. So start with that basic nursing education and become grounded in understanding who they are as a nurse. Right. Because I'm one of the other things I do is I do our nursing wellness program here at City of Hope. And so one of the features that they write about in the research that contributes to burnout is being in the wrong job for who you are. And so you really, I think, can't know what the right job in nursing is until you have had some time providing frontline care, getting to know the patients, if somebody had said to me when I started out, because I was an ER ICU nurse for the first half of my career. And if somebody had said to me, you're going to end up spending the last part of your career in oncology, I really just wouldn't have believed them, because I found the thought of the disease kind of frightening.
Right.
And what happened to me is I was seduced by the caring that shows up amongst the staff, amongst the physician providers, and how they interact with patients. And because it's often a long-term relationship, you have the opportunity to make a difference over and over again in people's lives. If you don't like that kind of intimacy, it's not the right role for you.
Right.
I mean,
yeah, I would agree. I mean, nursing for me is my second career, and I think it is interesting to find nurses that have sort of the right mix to go into research. But I do think it's good to ground yourself in a good understanding the clinical practice of nursing and who you are as a nurse. So I have a research background. I worked as an epidemiologist actually in heart disease before I came into nursing. And when I came into nursing, I just thought I was going to have to learn, pay my dues. So I took this job on an oncology floor. It was very quiet the day I interviewed. That was the last time that ever happened. And then I found I loved the science and I loved the challenge, and then I loved the patient contact and the support. And I love nursing, actually. Nursing is a great career because it's not just the caring. It's also, to me, it's the science. It's what we know and bring to it. And Kate's advancing the field. You're advancing the field, all the nurses who are doing that work. It's when you see discoveries being made, or you find out that when I talk to patients about breast cancer now, and when I first started out, Herceptin was just being in clinical trials.
Right.
And now women who have HER2 positive cancers have tremendous, we've made tremendous success. It's really, it is part of that hope. And I've had patients, I talked to once a young woman who had a blood cancer, but and her cancer was very aggressive. It was sad, but she was thinking about a clinical trial and she just wanted to talk to someone about it for a while. And City of Hope is unique in that nurses, there are people that they can talk to, either the nurse giving the care. It's a team approach. And I was able to talk to her, but she said, I don't know what it'll be like for me, but I want to help others. And so our patients who come and say they want to help others, it's really humbling to hear them do that. So I started losing my train of thought, but you need the clinical side, you need the patient side, there's the science you bring into it. And I think nursing is great in that you have an opportunity to work in different areas and bring that experience that you have to a new role here. I think that's really a great thing about nursing too.
I had forgotten to mention this, and my department colleagues are not going to be happy with me, but we actually have a study right now on clinical trials.
You do.
And it's a shared research project with City of Hope and the University of Pennsylvania, running programs that are transdisciplinary in clinical trials. And I think...
Is it phase 1 quality of life?
I don't...
Is it phase 1 quality of life?
No,
It's
not that one.
actually educating.
It's educating research nurses and
Oh,
helping
that
you accrue more patients, because there's a very low accrual rate among the United States of participants. I think it's 3% or 2 to 4% of patients enroll in a clinical trial.
It's in the adult population.
We're in the adult population.
Yeah.
And here at City of Hope, 16 to 18% of our newly diagnosed patients enroll in clinical trials. So the amount on clinical trials is much higher. So we, we're very much a research facility, but that's what that program is. And they have it in different, I think they rotate where they have it so other places can send their nurses, but it does help with how to be a research nurse, how to improve your accrual, because the community centers, research has a lot of work, a lot of tasks that you have to do. It's not easy. There's a lot of regulations you have to follow. So you have all these people in different places. And I think it's hard for a community practice to have all those structures in place. So this kind of helps them make sure a research nurse knows kind of her guidelines that she has to follow, keep everyone safe, not only the ethical issues, but also the patient protection, and then how to accrue patients. So you're right, they do have that, and it's a program, I think they've been doing it for a couple of years.
Right, I think are we coming up to our last year in that program? But what tends to happen in our department is they tend to look for another source of funding to continue the program or to institutionalize it, like base it here at City of Hope and run it as a ongoing program from the institution's perspective. My guess is that some of that will be discussed in the next year and plans will be made to continue it, because it's that community people around the research facilities that don't have access to the education related to the science of doing the studies.
Right.
And people you'd hear, I think, probably less of that. The other comments of being skeptical about participating in research if people really understood how it's approached in such a well-organized and thoughtful way.
That's great to hear.
So I think something like that conference or program is good if you're interested, if you can get in. There's also ONS has a class that you can take and get information. I actually got my master's in science and nursing. That's the focus in clinical trials administration. So there are, I mean, it is upcoming, so there are ways to advance your knowledge. And I think just having that desire and getting a community, that LinkedIn has clinical trial groups. The SIGs for ONS has a clinical trial. So I think if you're interested, just reaching out and, you know, connecting with some of these people, because again, it's not always, definitely you want to have clinical floor experience, but it's not always you have to have research experience. Sometimes it's just that desire to learn, because there's a lot to learn, very rewarding work. But I think because of all the different things that you do, you want to have that desire. So I think just by showing that you're interested in taking these classes or doing these conferences, connecting with people, then, you know, that's a really good way, I think, to get into it.
Yeah, I couldn't agree more, and I'm really glad you mentioned the professional organizations, because you can at any point in your career participate and find, particularly ONS is very good about having the different levels of presentation at their conferences and just the contact with people. I mean, you will begin to discover whether these are your people or not very quickly when you're at those conferences.
And the conference that Kate is referring to is the Oncology Nursing Society. And they usually have the ONS Congress every year in the spring. And I know that both Kate and Kathleen mentioned how they got into nursing research, but I also want to find out from Pam, how did you get into nursing research and ended up getting a master's? And
I'm all in. So I actually, nursing is also my second career, and I worked in a pharmaceutical company. And I worked with a nurse that was a manager that worked in marketing. So she actually traveled around to find out if they were going to develop a drug for, you know, some kind of disease. She would talk to the physicians and scientists, like, what would you want this drug to do? Like, what are the side effects we want to control, different things. And I thought, I never knew a nurse could do that. Who would think of that? I mean, I just thought it was so amazing. And this group of people, and working in a pharmaceutical company, you know, you had the project, so you had a whole project team. And they were so passionate, and their drug pipeline was, you know, always had to put money into research. And everyone was really focused. And I think I worked at a company when it was naproxen was approved. So it was just the feeling of, oh my God, we did all this work and now it's approved. And I thought, wow, that's great. So I went into nursing. It took me 10 years to do actual nursing and get there. It was a long road.
That's okay.
And once I did, someone did talk me out of oncology, because oncology was always my focus. And they didn't have a good understanding. But, you know, 2 years after I ended up going to oncology and going into outpatient. And, you know, I loved it. I love the patients. I think patients that are at their sickest are so grateful for every little thing you do. So cancer patients are amazing. And then of course with that, there's so much research. It's, you know, tons of research opportunities. So I just started really learning oncology, and I became a travel nurse, and I went to lots of NCI comprehensive cancer centers, because I knew that's where they do research. So I went to Yale, I went to the National Institute of Health, Stanford, UCLA. I'm very glad I'm here at City of Hope and not as a travel nurse, but as, you know, an employee. And then I found the master's when I was at the National Institute of Health at the George Washington University. And now there's even more programs, but it was probably the only one that had that, because I did want to get my master's, but I really wanted to stay with that research side. And so I did. It was in clinical research administration, and I worked with other research people. Not all of them were nurses. So it was very interesting, just, regulatory people,
Right.
research coordinators, project managers.
Mhm.
So I really get that business side,
Mhm.
that patient side, that science side. So I kind of get everything that really
Right.
I'm passionate about and want to do. So I'm in it. And I hope to stay in it for a long time.
Good.
That's great. Now, how do patients get selected for clinical trials? Because I know here at City of Hope, we do so many. What's the process? And
We do, and I think we're really lucky that there's so many physicians that are aware, they're specialists in their field, so they're very aware of what's coming. A lot of them do their own physician-initiated studies. So they're usually will know if the patient is someone that may have a study. We have a study open, but they also know that we have a long list of studies. So if a patient has a diagnosis and there's not a lot of treatment options, or the treatment option is not great, they'll look through to see what we have to offer. We have patients that I know I've talked to, and they'll say, well, I know if this doesn't work, there's another one that I'm qualified for. My physician already told me. So, luckily we have a lot of open trials. And it's a thought, right now there's a lot of diagnoses that don't have a cure, that don't have great treatment. So these new things that are coming out, it's kind of on the forefront of everyone's mind, and we know there's something out there. Or if we don't have it, maybe someone else does, but we can also put it out to our community practices so that we can reach out to more communities. So I think the physicians know. We can also look through, new patients that come through to see if there's anything we can offer them. They also call. And a lot of patients are, with technology now, patients are very smart and can go on clinicaltrials.gov and search for any trial, and then it'll tell them who is doing those trials. So we can get those trials. We're also very collaborative with a lot of universities. So if they know we have a study for their patient, or because our physicians are specialists, they're at conferences meeting other physicians, and they know who has what, so we can refer them out. A lot of them are referred in just for the study time. So I think, there's a lot of different ways patients can come to us.
And how do these clinical trials help others, and what happens when drugs get approved through the clinical trials?
Oh, well, when the pharmaceuticals, like for example, right now, we have quite a few industry-sponsored clinical trials, which are either looking at phase 1, which is first time in human subject trials. And in those trials, they're typically looking at dose-limiting toxicities and tolerance, and safety and efficacy, basically, is what they're looking at in those. And then as you move through the trials, the FDA approval, and it's the FDA who awards an approval that the drug can be used for whatever it has been conceived of and tested to address. So, and that's called the indication for the drug. And so once you have that FDA approval, then it might be further tested against the standard of treatment or against other drugs who do the same thing to see if there's less side effect burden. So once they make FDA, doesn't mean that they're done being tested or evaluated. And so there may be trials with drugs that are, in fact, FDA approved, but they're testing it against this standard of care as it exists now. So that's the kind of the process. I will say here that we've made a very significant effort for the disease teams to not only work as a team to identify their priority studies and the questions that they want to introduce, and therefore the patient populations that they are going to direct their efforts at recruiting. But then they also collaborate internally, and as Pam mentioned, they collaborate with other institutions across the nation. So that collaboration is feeding the research benefits and knowledge and evidence production for a variety of different strategies for managing the disease. And islet cell is a perfect example of a way in which multiple centers were working on an issue and have come forward with research to make something really happen for patients.
What have been the challenges of being a clinical research nurse?
I think for me at one point, I've worked with some patients that were very ill, and it was them actually being on this trial to help people down the line. Not that it was a cure, but even though they're told that and they sign that, at the back of everyone's mind, you know, they are thinking there's that one little piece of hope. So I really had to learn to understand that everyone has hope. If it means 3 months to see their grandbaby born, or to be at their daughter's wedding, or whatever the reason, lots of celebrations, that I have to be okay with that. I can't put any of my thoughts onto what someone wants to do with their life or how hard they want to fight. So I think that was the biggest part for me. And once I did get over that, because that was kind of my point, like, do I want to continue this? Because I want to be valuable. I want to make sure that I'm being ethical, but I don't want to impart any of my beliefs on someone else, because I'm there to support their decision, and also protect it. You know, if there's guidelines that I need to be aware of. So there's a lot of things you need to know, and question, and know that it's okay to question, because you're still an advocate for the patient.
Right.
But all that can be a little overwhelming at times, you know. So for me, that was a challenge, and I think in research in general, it's the amount of resources that you need to do, you know, the community practice that don't have that. So I think studies and clinical trials in general are not just for any one facility. It's really trying to reach to cancer patients in general, and that's why we collaborate with others. We open up to community practices so that it's available for everyone, and it's out there for all cancer patients. So I think that's just a challenge of how we got in there. I think we're doing better, and I think we're constantly working on it. But, you know, everything's still a challenge, all the work that has to be done.
I think that one of the challenges to the research nurse is that you need to stay up in the field. And actually, one of the challenges I find at City of Hope is staying up with all the discoveries and the new studies that come here, so that when people do call or physicians call, we can let them know. City of Hope is doing some very exciting work in immunotherapy trials and our T cells programs, the alpha clinics, stem cell research, and people call us or email. People are very, very interested in what might be here, and they're looking for that hope that there's something here that they hadn't been able to discover before, whether it's in the community or here at City of Hope. And sometimes I think they call, people just want to know that they've explored all avenues. They want to make sure they've gotten the best information possible. And so they come to National Comprehensive Cancer Centers because we have the research, because we have the resources. And I think another good thing about patients who come here is we do have wonderful supportive care resources, like being able to have Kate come in, or our social workers that can help our patients as they go through the process.
I think it's still, for me, the challenge is the biggest challenge is the people issue in relationship to being with somebody and being with them during a time in their lives that's frightening, and that they're trying to figure out what does life look like during this process and after this process, and the changes in their roles and their relationships that occur because they're in the treatment process. Many of them have positive outcomes attached to them, but the process of changing, the process of making those adjustments is really huge. And in the role in research that I have, and in the role with the hypnosis, my job is really to hold a lot of that anxiety. And sometimes that's heavy. So this goes back to the nurses that we're looking to have come join us. Have a rich life yourself. Come here, do rich work. but have a rich life yourself, because that is what's going to attenuate the burden of holding so much grief. So play a lot, laugh a lot,
Mhm.
all of that kind of stuff.
That's great advice. And what's the future of clinical research nursing here at City of Hope?
It's only going to get bigger,
Oh,
right,
It's only,
Pamela?
yeah, it's only going to
We've
grow.
grown so much. For my nurses, they're infusion nurses, but they're doing all the treatments for the studies, and the studies are only getting more complicated.
Right.
And we get phase 1, 2, and 3 coming through.
Mhm.
Phase 1, sometimes, it's never been given. We may be, the first one giving it. So just really being up on your clinical skills is important. Being very flexible, because you may be giving chemo to one, you may be drawing blood from another, and an EKG is timed. So also keeping the research nurses on their toes, because this is our clinical practice. So you may want, a lab or an EKG, but you need to tell us which one's first, because we want to follow the protocol. But as they're making all these things, some of these things, so we have to be on top of that to make sure we're doing it correctly, because if we're going to do all this work, we want to make sure we're hitting that protocol and avoiding any deviations at all, because we're here to do that. So we've seen an increase of 50% in my unit already. So we just keep growing out of space. Challenging also, because when you're on a study, you have to have the same day. Sometimes there's a window, sometimes they're not. So if a lot of people get enrolled and they start on Wednesday, then right now we have huge Wednesday just volume, or someone's just got approved for this and they have to start on this date because there's only, a 14-day window. So you have to take that patient. So, the nurses never know what they're going to get, because I may have added someone, like, we have no choice. They have to start today.
Right.
I've had nurses, work with the doctor that, okay, he's got to get his pain under control. And they're like, but he has to start treatment. And the nurse will stay there till 11 o'clock to make sure they get that study drug to avoid a deviation or making them fall off the study, because that can happen.
Right.
So I think there's just so many different things that are happening with research. It's not getting any easier, but that's why I think it's so important that you have to love to do this, because again, your day is different each time. Every study is different. We could have 30 patients and they could all be on a different study. So you may not be doing the same study over and over, but we also know when we're doing a study and that drug gets approved, the nurses are the first ones that did it. They know how it works. So when it's going out to standard of care, I think they're really useful, because they understand the drug, and you get to see the kind of the benefits of all your labor that you've put in. So I think it's only going to get harder, but better. The immunotherapy is going to be a little tricky. Sometimes you may have an oral drug with maybe a one-time infusion, a targeted therapy. So now infusion nurses that know nothing really about the oral drugs, now you may need to know a little more, because maybe they need that drug, and adherence to oral medication is difficult. So that adds a whole new realm of what we do, because now you need to make sure you know that oral drug, and you have to have some tools to keep patients on that oral drug as well as the treatment, which is challenging for any study. A lot of patients, I just want to miss this day. Well, on the study, you don't really get that option.
Right. There's no option there.
Right. So every day is, I think, new and challenging, and it just always goes to say is you got to love this, because it doesn't get any easier, but it's definitely rewarding.
And just to piggyback on what Pamela said, one of our trials when I first came into the department, do you remember this, Kath? It was on oral adherence to oral chemotherapy. It was one of the studies we did, total nursing study. And they were examining just what do you do to help people stay on their oral medications. And that kind of ties into the evidence-based practice and influencing nursing practice in a way, not just for your research population, but has payoff in other kinds of areas as well. That they're gonna continue to drive towards having more and more adults participate in research. In pediatrics, it's like 90+%, isn't that right, Pam?
Wow.
But people who are on study, so when you get Isn't that right, Kathy?
Pediatric oncologists years ago made a decision that every child that they saw, they would begin to enroll. So pediatrics has been managed very differently than adults. And in fact, a lot of the treatments that we use for adults started with children.
And so I think the drive for us too, that's another reason it's going to get bigger. And if you have nurses who are inclined in that way, and the demand for that kind of proficiency is really going to be great,
Right.
because we're going to want to expand that knowledge base, expand our opportunities to address a disease, because we've done the studies, we've developed the evidence.
Well, one thing that I'll say, and I always, my other background was in doing a different kind of research, but at one point I said, well, in a way, we already know. The knowledge is there, but then how do we apply that?
Right.
How do we get
Translate.
people to comply to oral medication? How do we educate the population and our professional colleagues, physicians and nurses, about what is best practice?
Very good point.
And so, that's one of the reasons I was attracted to nursing, because it's that point where you have all this scientific background, and now you're asking patients to partner with you, really.
Right.
And you're asking them to learn and step up. And I do think it will continue to grow. Nurses that have the skills to communicate, and listen to the patients, become their advocate, and explain things in a language that patients, they bring different learning styles or different needs that they sort of understand and get. So I do think it's going to continue to grow, and we want to advance the science. How are we going to do that?
Well, you touched on something there that I don't think we really emphasized enough, and that's the collaborative nature of the future
Right.
of healthcare. So I think historically, certainly somebody like me who came up in the early 70s and started practicing in county hospitals, not to put county hospitals down, but they were organized around a hierarchical model and a kind of a military framework where there was somebody always inputting how you approached care. And it was very clear that we were in charge, and with the doctor at the top of that pyramid, and that the patients were to gratefully receive our advice. And I think that what's changed today, thank goodness, is that the model now that's going to work most effectively in healthcare is going to be, this is collaboration. And the patient is in charge of that pyramid. So it's to flip completely,
Right.
and we are working
Yes.
for them. And so
That's
as
true.
we bring nurses, particularly nurses at the early parts of their career in here, we want people who can envision and endorse that partnering, because I think the only way to get it all done and in the most effective way is to partner with your patients.
Right.
They are your collaborators on this healthcare process and this journey. And they are the leaders, really. But us, we're collaborating. I see that all the time when we move forward with difficult things, and they really, in fact, it's one of the things I say with hypnosis. I said, this is a collaboration. This is all about relationship. We'll get a better effect if you feel comfortable with me and if I collaborate with you. And that's the foundation, that's the plank. And I really think it's the modern plank, don't you guys?
Yeah, it's partnering.
It's definitely partnering. And I think just oncology in general, with all the clinical trials, oncology nurses need to know so much more than they did before. It's not just giving a drug, it's like, which drug is that targeting? Is it a pathway? Is it, a general chemotherapy, or is it one of the new, monoclonal antibodies? Is it working with your immune system? So what are those side effects? And also, because of clinical trials, I think all oncology nurses need to have a little bit of understanding about clinical trials so they can help their patients figure out, okay, here's what you need to know about a clinical trial before you're on, because some of them may require lots of extra visits. Some of them may require long days, and if you don't have a ride here, that might be something you need to ask. Is it all of it's not necessarily under research? Some of it may be billed to your insurance, and part of it's standard of care and part of it's research. So I think some of that has to be clear. So just helping patients, really advocate for them. Now you have to add on clinical trials and have a little bit of understanding, so you can help them with what you need to ask or what questions you want to talk to your physician about. Is it right for you? And giving them resources, where they can go to get that information, so they fully understand what they're agreeing to participate in.
Yeah, and to build on what you said, we have a really strong role as being educators, right? So to help them, educate them and what the process is. And you do, I answer questions every day about how clinical trials are funded. And people think that they're all free. That's one that I get. And others, they have barriers to getting care, like transportation. And it is fortunate that City of Hope is really, I've worked talking to people in Idaho who have no resources, and we are, it's fortunate, and it's a team approach. It's wonderful to be able to call on other members, not physicians, our social workers, our nurses, experts. It's a real privilege to be able to work in that kind of setting. Yeah.
Our caregiver study that I'm the project director on is part of the questions we're asking is, one, how does this intervention assist caregivers and what is it they really need? But we are also, the study is designed to work with underserved and financially burdened patient populations. And in the writing of the study, which I was not part of, but in becoming oriented to it, what RPI has shared with us is that there's no good definition for the financial burden that cancer is. Now, we know it's like the most expensive disease to be treated.
Right.
But in this institution, which makes this, Kathy's right, it's a blessing to be able to have our colleagues in social work, financial planning, all of that kind of stuff, because you can talk to somebody who says, oh no, we're cool.
Right.
And then they find out, particularly with the changing marketplace in
Right.
healthcare insurance, they find out maybe they're not so cool, and
Right.
whoops, we really need to get our act together. So you have the people who are obviously going to be fragile coming into the system, but then you have people who think they're okay, and then they tumble off the mountaintop when the reality hits them. And so it is absolutely essential that we have the social work team out of supportive care, the access to our financial planning department, because they have access to resources that keep some of our families safe.
It's true.
And it really is a safety issue, I think. And without those pieces, this research wouldn't get finished because people would bail on it.
That's true.
I think we are lucky because even, we have patients that get treated and come back and volunteer.
That's
So I know
right.
we've had
Oh, what a
patients
good
that
Yes.
will stay with another patient, they stay with them the whole day and they have a long treatment. So I know for us, it's nice, you'd love to be with your patient all the time, but you can't. But having a volunteer that is with them, that gets whatever they need, I think that's just amazing. We have that ability and those resources that other places don't. So we are lucky because it does take a team, and we do have to collaborate together, all of us, and making sure the patient is put through this clinical trial safely.
Right.
And at the end, hopefully we can all, rejoice in the final rewards or the new treatment that comes up. And hopefully we're all in it for, the cure that we hope to find one day. So.
It is.
Yeah, that's another thing, teamwork amongst the professional staff. So it's not just collaboration with the patients and families. That is something I see from at all different levels as I cruise through, because I'm traveling through a variety of different locations within the institution. And it's obvious, the teamwork and the collaboration going on within the different departments. That's very nice.
All of you being here and being our expert panelists. And very interesting topic. We're very lucky to be here at City of Hope. And Kayla will go ahead and close out the tweet chat. And she has a few announcements.
So our next tweet chat will be December 22nd, and it will be on Hope for the Holidays. We hope that you join. You can also check out our jobs at www.cityofhope.org/careers. We also have walk-in interviews for our experienced nurses. They are on Thursdays from 7:30 to 2. And we are holding them at the Michael Amini Building, and that's at 1500 Duarte Road in the city of Duarte. Park in Lot A, and we're right across in the Amini Building on the first floor. And we want to thank everybody for watching us, and we'll see you the next time. Thank you.
Bye-bye.